from the University of Kansas Health System.
I am amazed. The team here is great.
I came on a Tuesday, and then by Saturday I had a heart in me.
I have never seen a group of people work together so good as this team of heart specialists. I mean, it's just unreal.
Stand by to set up show.
And the Dolph C. Simons Jr. Family Broadcast Studio.
Roll it.
Always makes you feel like you're the most important patient on the planet.
I felt heard, and that was really big.
This is All Things Heart.
Good morning. It's Thursday, April 7th. I'm Alexis Del Cid. Welcome to All Things Heart. Here's what we're talking about today. All right, women, yes, we can have it all. Unfortunately, that also includes menopause. So this morning, we're answering your menopause questions and showing you how a local mother of two with a family history of heart disease is planning ahead. And we're taking you behind the scenes, AKA behind the mask, showing you what two amazing doctors you're about to meet like to do in their personal time. And we all know eating right and exercising are key to a healthy heart, but do you know your risks? How to make sure you ask the right questions to take care of yourself and your family. And as always, if you have a question or a comment, you can share those on our Facebook Live, our YouTube channel, or just email us at allthingsheart@kumc.edu. We are everywhere. This morning, we're talking about something that technically only happens to women, but it can affect everyone around you. Menopause. Whether you've been in the car when your mom blasts the air conditioning on a frigid January day, I remember that, or you're the one waking up pouring sweat and suffering terrible mood swings, or maybe you're a partner who finds that suddenly your partner has no interest in intimacy or finds that intimacy is excruciating for them. Any way you slice it, menopause can be a doozy. Hormone therapy can help, but what does that do to your heart? Can it affect your heart, and should you consider it? We spent the afternoon with a Kansas City mom of two little ones. Now, she's not there yet, but she knows it's coming, and she wants to be prepared.
Shannon Cochran says there are two small gifts that prompted her to laser focus on her heart health in a big way. Remy, who's at a balloon party on this day, and Reese, who's in her arms right now, living her best life.
I was 35 when I had my first daughter and 37 when I had Reese. So yes, heart health is certainly something that is top of mind for me. Being a little bit of an older parent, I want to prevent any health issues with myself that to not disrupt their childhood.
While she and her husband do a great job of documenting their family, when it came to Shannon's family history, she had to do some digging. And when she learned of one of her great-grandmothers who had suffered multiple strokes and one of her grandmothers who had a quadruple bypass and a debilitating stroke as well, it was a red flag.
Just to see that direct family history of heart disease and stroke has really brought to light what I could be facing if I choose not to do things to prevent it.
As a dietitian, Shannon already lives a healthy, active lifestyle, but now she's planning long-term, including what happens when she hits menopause.
I do know that my personal experience with changes in hormones has been very drastic, whether it's been with pregnancy or delivery or breastfeeding and weaning the baby. I always have a very significant response. Physically, I get very sick with fluctuations.
She's already investigating her options, and that includes hormone replacement therapy. But before that happens, she has plenty of questions, including what effects, if any, will hormone replacement therapy have on her heart, knowing her family history.
We're so excited to have two experts join us today to answer all of your questions and Shannon's questions. We have cardiologist Dr. Shannon Hoos Thompson, thank you. And we also have OBGYN and Vice Chair of the Obstetrics and Gynecology Department, Dr. Maudrey Reddy. And thank you for being here. And we also have our mama, Shannon, who joins us virtually. So I don't see two little human beings climbing on you. You must have found a way to escape for this brief moment. Do you have a full house today?
Not today. They are all in daycare and, well, napping. So one's here.
That's good. So you got to take advantage of that.
Yeah.
When you say you're focused on heart health, I got to start with this because you're not kidding around. I want to show you viewers a picture of that your husband took of you doing a little light reading. Kate, what is that book called?
The book is titled How Not to Die.
How Not to Die. So you started reading books like this. after you had your 2 kids, because you really want to maximize your health, you recommend that we should all check it out?
Yeah, it's really good. It's really easy to read too. You can pretty much jump to a chapter, and it's specific to a certain disease and tells you certain lifestyle changes or dietary modifications you can make to help prevent whatever disease it may be.
I want to bring Dr. Reddy in right away. We're talking about hormone therapy. A lot of people call it hormone replacement therapy or HRT, but you really prefer to call it hormone therapy.
That's right.
And why is that?
I mean, I think officially that was a little change that a lot of the medical societies did because of kind of having that, take away that misunderstanding that we're not actually replacing all your normal levels of hormones or anything like that, which is probably impossible. So what we are really aiming with hormone therapy is helping with symptoms that people suffer through, when they're going through perimenopause or menopause.
And this affects so many areas of health. Dr. Thompson, as a cardiologist, you've told me that you work very closely with OBGYNs on a lot of health issues. Why is that so important to have that collaboration?
So I'd say more to kind of frame that is that the overlap. We recognize that women during pregnancy is a time when we can really start to recognize what the heart risk is or things that we need to work on at that stage in their life that can set them up for better things from a heart standpoint later on in life is really where that collaboration really comes in.
I want to ask Dr. Reddy, how common is it that women come to you suffering really uncomfortable menopause or perimenopause symptoms and that you would recommend or they would ask about hormone therapy?
Very common. That's probably my 50% of the practice, really.
50%?
Because I've also been practicing for a long time, so a lot of my patients are in that age group where they're going through a change or they've kind of found that that's one of the primary interests I have. So a lot of times people come to me for those questions. So I do see a lot.
There might be women who, in perimenopause, for people who don't know, that's right before you hit menopause. So what are some of the symptoms that someone watching might be having right now that they're not identifying as perimenopause or menopause?
Well, going back a little bit, the menopause is a clinical diagnosis, so you only diagnose menopause 1 year after it starts. So basically, the last period that you have 1 year after is when you call it menopause. So anytime before that, so start of your symptoms, hot flashes, whatever symptoms you have, to that 1 year past your last period is considered perimenopause. So perimenopause time, you're not completely, you don't really have low estrogen or high FSH. Those are the hormones we kind of associate with menopause, but you have a lot of fluctuations during that time. So the symptoms can come and go. So therefore, the way you treat during perimenopause is very much different than how you would treat during menopause.
But those symptoms are those raging hot flashes,
mood changes, sleep disturbances, a lot of the weight fluctuations, all of those things really are more during perimenopause. So during menopause, kind of things stabilize almost, I feel like.
Well, when I was talking, Dr. Thompson and I were talking, and you had said, you really want to address some of the misconceptions that people watching might have about hormone therapy and menopause. And what are some of the big misconceptions that you encounter?
So I think you have to understand a little bit historically. So in the late 1970s, 1980s is when we first really start to recognize how big of an issue heart disease, especially coronary artery disease, was in women, that we were underappreciating and really undertreating, and we need to do better. And so we started to do some studies. And one of the things we recognized is that women after menopause, it seems like their risk for cardiovascular events seems to escalate or increase dramatically more than, say, women who have not gone through menopause or men of the similar ages. And so one of the theories is that, hey, let's use hormones. If it's because they've gone through these hormonal changes of menopause, maybe that's where we can continue some sort of replacement therapy or keep them back on what we consider normal levels when they were 40 versus what they are when they're 60 and see less cardiovascular events. And when they actually put that to the test, it's like, nope, that doesn't really work. So putting women on hormone replacement therapy or hormone therapy of any kind, it's not going to decrease the risk of cardiovascular events. But when you're going through menopause and having all those symptoms and problems where it's really affecting your life, is it safe? The answer is yes. You have to be aware of some things and pay attention to your overall health that can set you up for other adverse events. But if you're doing that, can you go through menopause, and especially the early stages of menopause, and be on replacement therapy with hormones? Yes, you can.
I want to bring in our patient, Shannon, our mama, our patient, our busy mom. Is that reassuring for you to hear? And were those some of the questions that you've had about this as you look ahead? I mean, you do read a book, How Not to Die. So you have been planning, what are you going to do when you do hit the age of perimenopause or menopause?
Yeah, absolutely. It's very reassuring. And I think, my age now, I'm 38, I'm starting to think about perimenopause and what that is going to look like. And just to hear that it's safe for my heart to be on some sort of hormone therapy is very reassuring.
I want to bring up an illustration that we have that we want to show our viewers, and we want to show Shannon too. It's a stoplight illustration. Red, yellow, green. So we've talked for the most part about the safety, but I want to start with red light. That's patients who should not consider hormone therapy. Dr. Reddy, what do you think about this as far as high risk women?
Yeah, I think that is accurate. I think people who have actual history of some sort of a clotting disorder, stroke being, could be one of them also, would be contraindicated, to have hormone therapy. Now, known breast cancer is technically definitely a contraindication because a lot of the breast cancer is hormone positive, like hormone receptor positive. So that's why it's in the contraindication list. But sometimes we work with our oncologists because some people who have breast cancer that is not hormone receptor positive.
Right.
So sometimes we work with our oncologists, and if that's the case, that's the type of breast cancer the patient has, and the patient's really suffering, debilitating symptoms of menopause, we will work collaboratively with our oncologists to kind of see if that's a possibility for the patients.
And Dr. Hoos-Thompson, you're nodding your head yes as we go through that list. Did you have anything that stuck out at you?
Well, I would say whenever you're addressing this, you look at all the factors. So you think, just hormone replacement or hormone therapy. The answer is it's all of the above. So you have to look at the overall health of a person and then decide, okay, how stable is this or how significant a risk is this? Because it's not just a yes or no. There's a whole lot of in between there. And if you can work through and really determine the specific risk with that specific condition, and then what's that mean when you combine it with the other, and then put it into play with a specific patient that you're talking with, and you can make a lot better decisions there.
Right.
So I think way too often we try to label it as black or white.
Right.
Black or white. But the answer is there's a whole lot going on in between, and you can really individualize that, and we have the technology and the understanding to make better decisions. So I think the biggest thing is you have to be aware of those things and be able to discuss them, but a lot of times you can work through those issues or modify a lot of different risks before you get to making the best decision for that person.
I imagine that helps when you've got doctors, great doctors that are working together and collaborating and are on the same page.
Yeah, you can't be an expert in everything. You try to be a good doctor, but there are situations, and again, when you're trying to really refine and whittle down to the core of what do we have to do for this person, this individual, that's where knowing the expertise of the others or being able to get that information without spending you don't have enough time to read big books constantly after you get out of medical school.
Unless you're Shannon.
So having somebody who's read that big book and telling you what they found out from that big book, or and there's a lot of information out there that gets very convoluted. So how do you work through that convolution? That's my word of the week. That I think is a real challenge of health these days, and way too often it ends to putting in a negative percent. Oh no, it could. What if? And the truth is, know what you know and deal with that. And guess what? A lot of really good things happen when you stay aware of what's right in front of you.
We're talking about the in-between. There's no black or white or red or green. There's the yellow. So let's go down, again, back to our stoplight. This is the proceed with caution, where you have a definite risk, but you should proceed. Diabetes, smoking, those would be two big risks. Now, if you're a smoker or you have diabetes or you have a sedentary lifestyle, you can still consider hormone therapy? That's what you're saying.
What I see is a list of things that can absolutely be treated and controlled. Okay. So if you can treat your diabetes, you can get rid of smoking, you can manage your weight and your lifestyle, migraines are manageable, high cholesterol, all very treatable and modifiable things. So guess what? If you do those things, one, my suspicion is your menopausal symptoms will get better when you manage those things.
A lot of
but
times.
two, you can absolutely use replacement therapy or excuse me, hormone therapy. And
My
I would hope you'd agree. Hormone therapy.
Yeah.
And see, I've been trained wrong.
But I love seeing this.
Yeah.
I
And
love
that's
seeing
where we
this
have to
dialogue.
interact.
Yeah.
But would you agree with that? If I say, hey, we're treating all these risks, and this person's making a committed effort to managing their risk, guess what? It's gone down, and so now can you go after the other side of it?
So all the things on the list were things that cause vascular disease, right? So I think the whole thing is if you control those diseases and control your vascular disease, then your risk of clot goes down.
Right.
So which is why you can do the hormones. So the red light were all the things that cause clot.
Or
Right.
it's already happened.
It's
been
already
there. If
happened.
you look, those are lists you've had clots, and now
Yeah.
you have to potentially make decisions about things that otherwise can also further provoke clots. So if it's not a controllable or reversible risk, you're stuck a little bit. But a lot of those other things, very manageable. And just a great reason to reinforce that, hey, we've got to go after these things too.
Right.
You want to control your symptoms with menopause, so do we, and we want to do it safely. Guess what? All the more reason to attack things like diabetes, smoking, cholesterol, lifestyle.
What's the deal with migraines with an aura? I would never associate that with I'm not a doctor, obviously, but I would never associate that with those other risks.
From what my understanding is, migraine with aura is also a type of vascular disease that's more affects the brain. So you
Reactive
can have
vessels.
reactive vessels. So if you have reactive vessels and you're putting estrogen on top, you can increase. Estrogen increases the baseline risk of clot. So if you have reactive disease, potentially you could have a stroke, increased risk of stroke.
Then we have the green category, which green means go. These would be women who are very low risk or lower risk, recent menopause, normal weight, healthy lifestyle, normal blood pressure. But you wouldn't just tell anyone to go for hormone therapy willy-nilly. You'd still have them talk to all the specialists, right?
I think the main thing I always say is that we're treating symptoms.
Yeah.
So it's not a preventive therapy. We already proven that it's not going to prevent heart disease. So you treat menopause for symptoms. So if you have recent menopause and you have symptoms like hot flashes or things that are really affecting your life, then definitely that would be the group I would consider hormone therapy for.
Shannon, when you and I were talking when we were at your house with our photojournalist Alex, you had talked about hearing about different kinds of hormone therapy. What are the kinds of things you had heard about? I think we talked about pellets. I remember my mom got pellets under her arm when she was going through menopause. What have you heard about what's available out there? And I want to run it by our experts.
Yeah, so I've heard of the pellets, testosterone, I believe, and then maybe patches.
Mm-hmm. So what do those look like? Do they still do pellets and patches and things?
Patches, definitely, and oral preparations. They're creams that you can put on the screen, on your skin, and there are also some vaginal preparations that also get absorbed through the vaginal skin. Pellets, I personally don't use them because once you put them in, you just can't take them out if something happens. So
they're just in you until it wears out.
Right. So I usually don't use pellets. I know there are people out there who do that, but usually I will prescribe more through skin. Transdermal is called, or oral.
Okay.
So that's, and then all vaginal, transvaginal.
I want to get to our community questions because we're getting a lot of them, and we also had some that were submitted in advance. Marie had asked what it consists of, and we just addressed that. Bridget had a question. She said, while using hormone therapy, are there annual tests a woman should have to ensure early detection of a serious side effect? Dr. Reddy.
Okay, so I think when they did the studies, they talked about hormone use, especially estrogen and progesterone use. They saw that after about 5 years of uses was a small increased risk of breast cancer. Because of that reason, I always, very strongly recommend if you're going on hormone therapy to get the mammograms to screen for breast cancer. That would be my primary screen that I continue, but all the other preventive care that I usually have our primary care physicians who do a wonderful job follow in terms of cholesterol screening, the regular screening that we do normally.
Our Facebook page is getting tons of questions right now, so keep them coming. I'm going to keep asking the doctors your questions. Amber would like to know, what about breast cancer risk? Many women seem to be afraid of increased risk with hormone therapy. Dr. Hoos Thompson, what do you think about that?
It's relatively low.
It's
yes,
so
it's
that
something
would
to
be
be
a
aware, but is it
misconception?
something that you should do extra screening or change your screening protocols or reasons to look? The answer is it doesn't. That's really not the case. Like she said, usually somebody's average menopause is around 51, right? The risk really doesn't change. So in hormone therapy in those early years, like they said, we've actually studied this is well-documented things. 5-6 years, early menopause, being on hormone therapy, really there's no significant problem. If you're someone who has to be continued on hormone therapy for whatever reason after that window, that's when you maybe need to be reassessing what is the risk or what's the benefit, what are we doing? And I would say that's, again, kind of an area that we don't have as good information on, or we know there are potential increased risks, at least from a cardiovascular side.
Right.
From a cancer side, I'm not even sure we've actually fully worked through that aspect.
Oh, interesting. Okay, Jill has a question. Is hormone therapy safe for someone who had a total hysterectomy at the age of 39? I've been on hormone replacement therapy, HRT is what she's calling it, now for 11 years. Dr. Reddy.
Yeah, so, again, when we are talking about research studies and trying to apply it to people, sometimes they're not apples and apples, because research studies are very much done on a very prescribed, defined group. And a lot of the hormone therapy studies are done on 50-year-olds, average age of 65 in some of the key studies that we quote often. So it doesn't apply to a 30-year-old who's gone through menopause,
Right.
So for that patient, yes, you don't stick with the 5-year rule of, do hormone therapy for 5 years and then we'll see if you need it, because that doesn't really apply to that person. So I would treat the person in front of me, and that's true even in menopause. Somebody is having debilitating symptoms, say they're done with 5 years worth of hormone therapy, we reassess, we talk about what's happening. If the symptoms are continuing and they're affecting our daily life, we talk about risk and benefits and treat that person in front of us. It's not a cookie cutter everything.
I like that expression.
She's spot on.
So it's just that's the main thing. You have to treat the person and their life, because it's a symptom management. One of the things we need to look at menopause is it's not a disease process. It's a natural progression. So you have to kind of help the patient live the best life they can at that time.
Another question I got on Facebook is hormone therapy related to belly fat? Or is hormone related belly fat a risk for heart disease or other disease, and what do we do about it? Hormone related belly fat, what's that?
I think
Who
they're
wants to go
talking about,
first?
you can go ahead.
So we've looked
fat.
at different adipose content. And one of
Okay.
the things that we've studied, and it's usually more academic because it is true scientists, as far as have we applied that clinically, we haven't really found the connection. But as far as where your fat is, what kind of fat it is, there's some information out there, and you can absolutely find it. But again, I like my word convoluted. You have to be careful how you apply that. And again, you keep it in perspective. What's their blood pressure? Do they smoke? How's their cholesterol? What's their blood pressure? And if you manage those things, the fat's going to be in the right place. So fat is not a complete enemy. We have to have it to some degree. But adipose content, whether it's more abdominal versus, we even look at the fat content around the heart and around the blood vessels of the heart. So the answer is there's some data out there about that, but really by itself, we usually don't use that as a marker or something we specifically go after.
Jody has a question for Shannon at home. Shannon, Jody wants to know how you've changed your lifestyle since you went on this journey to discover different ways you could be heart healthy and discovering your family history. What are the big changes that you've made?
I think the biggest thing is I've changed my exercise routine. I've incorporated a lot more strength training in addition to cardiovascular exercise. But I would say, 2 to 3 days of strength training or yoga in addition to, walking or biking. And I'm also just a lot more conscious of what I put in my body. I'm trying to eat more whole foods, not as processed. It's hard having 2 small kids and working full time to not eat what's easy. I think the biggest thing is just staying prepared and having, healthy food available is also key.
Well, especially when you have 2 little ones at home. You're constantly herding squirrels when you're at that stage of your kids in their childhood. I have a question from Tammy Griggs Vanlerberg. She wants to know, is bioidentical HRT safer? Well, I don't know what bioidentical hormone therapy is. What is that, and is it safer?
So technically, bioidentical hormones means that the hormone that you're taking is chemically same as the hormone that you make in your body.
Okay.
Okay, so that would be bioidentical hormone. So you can make a bioidentical hormone synthetically in the lab, or it can be coming from a natural source in the nature. So
like something you eat.
Something in the medications,
Okay.
like in the medication preparations, you have a bioidentical hormone that came from, say, some sort of an animal per se,
Okay.
so that kind of thing. So I think so by a lot of times though, in the when I have patients come in and talk about bioidentical hormones, they're talking about hormones that they maybe get customized compounded hormones from a compounding pharmacy or something like that. So we don't know the source of those hormones. They could be from natural sources. They could be same as synthetic sources from the lab. So I think that's what they mean by bioidentical hormones. In terms of risks of bioidentical hormones versus non-bioidentical hormones, there's no good data that one is safer than the other. So anything you read about it is a lot of times an expert opinion. So it's an opinion. It's not anything proven fact. So you have to take that with a grain of salt.
Joellen has a question, and she's sharing something as well. So Joellen writes, for ethical reasons, I declined hormone therapy years ago. No regrets. Are there other alternatives now, and are daughters and their mothers' experiences similar? Like, are we going to get what happened to our moms? Who wants to go first on that one?
Oh, that's all you.
Okay.
So it all depends on the symptoms. So
Okay.
again, we're treating the patient in front of us, so you have to kind of understand what are the symptoms they're presenting with. So if it is hot flashes, then definitely there are some options. Estrogen works the best for hot flashes, but doesn't mean that's the only option, because there are a lot of patients who have contraindications for estrogen, like we saw. So in that situation, we will use other preparations, commonly an SSRI preparation. One of them has an FDA approval for treatment for hot flashes. There are some non-FDA approved medications that sometimes we will use as well.
Dr. Hoos-Thompson, I have a question that relates to something that we talked about, which is managing other symptoms you might have, and then if that makes, oh, your beeper's going off.
I'm sorry.
Always a doctor. Don't be sorry. You're a cardiologist. We'll let her check that right now.
It's okay.
Okay.
Let's move.
All right,
Maybe I was
move
just
on.
trying to get out of the question, and I'm going to let them know that it wasn't that bad.
No, and thank you again for both making time between seeing patients to come on our show here. Tammy shared, I have high cholesterol, but I manage it with diet and exercise, no meds. I keep my numbers right under normal range. So is it safe for me to be on hormone therapy? Would that?
Yeah, absolutely. So, and that's the best way to do it. So it's always ideal if we can do things with lifestyle and with make sure that we're paying attention to how you're taking care of yourself day to day. That's always the best way to do something. And then we use medications or other interventions to take it to that next level, or at least even as a bridge potentially, so until you can get a better management of what you're doing and how you're living your life. So so the answer is yes, that would not be an issue for me.
That's such good news for women to hear who are watching. I want to just check back in again with Shannon, our mom at home. Do you have any questions that you want to ask the doctors while you have direct access to them? Because if you do, I want you to jump right in. Was there anything you heard today that you thought, oh, I didn't know that?
I guess my only question would be probably from a OBGYN standpoint, would you say that keeping annual exams is a way to stay on top of this and continue the conversations with, my physician as to when and if it's the right choice to start hormone therapy?
I think regular preventive care is important, and I think having, having a primary care physician work with your OBGYN is key. I think as you're getting into the perimenopause time, you probably will need more, closer relationship with your OBGYN to discuss the hormonal changes and what kind of things we can do to help you.
Thank you.
Angie has a question. Shannon, did you have any follow-ups to that?
No, that was great. Thank you.
That's good. Angie would like to know, are there any things we can do now to prepare for menopause that can help in advance? Because I guess none of us want to see what happened to the generation. I just remember my poor mom being miserable when she went through it. Is there anything like any of us could do now to minimize menopause?
I'm trying to think of that.
Or are we just, it's out there and it's happening?
I mean, I think each person's menopause is very different. You know, people always say, like, it may follow what your mom's menopause was, but that's not, you know, always true. So, you know, everybody is very, very different. Your menopause may be not what your mom's menopause was. So, some people have tiniest little hot flashes every so often, and other people are dripping in sweat. They wake up at night with the whole bed wet. So it's just kind of so one size doesn't fit all. That's the main thing. You know, do preventive care. If you have a comorbid condition like the diabetes, smoking, those kind of things, you know, work on those. That's what you could do to prepare yourself or keep yourself healthy.
Dr. Thompson, nodding your head in agreement?
No, I love having you here because you've covered my bases better than I've covered my own.
You're my new dream team.
Opening day, right? So yeah, she's covering the bases very well, and that's what you do. You know the circumstances and you prepare for it and you deal with it. And I think a lot of it is modifiable. And again, we looked at hormone therapy initially to see if it was preventative. The answer is it wasn't. But is it safe in that menopause time of life? It is, knowing that you have to pay attention to everything else that can impact what's happening. And especially things that can happen that are bad. We ultimately want to deal with what's causing you issues, and if we can do that and do it safely, then we absolutely should.
One of the things I absolutely love about doing the show is getting to know our doctors on a more personal level. And speaking of covering the bases, I want to show you all some pictures. Okay, this is our part of the show called Behind the Mask.
Uh-oh.
And well, who do we have here? I know it's not the umpire that we're looking at.
Maybe
Dr. Thompson?
Oh, I know those people. Yeah.
You were a college athlete, so tell us what you played and where you played.
Yeah, so half a lifetime ago, I was a college softball player at Creighton University. And it was a very special time in my life and a lot of really special people more than anything. Obviously, amazing experiences.
And you now have gone on to, and that's the bus driver?
That's Tim.
Who drove you guys
he
to
drove
the games?
us 10, 14, 16 hours. And
oh my gosh.
when I look back, I'm like, how he made it without having to stop just for himself to urinate. Obviously, we had we could go back and use the restroom on the bus, but Tim, he just kept us going. He got us back to and from the games and to and from school. And
he comes to the alumni events now, and you guys are all still friends?
I was at an event, or I try to go to a game once or twice a year, and I was there a few years ago, and there was Tim. It's like, Tim, what are you doing? And he looked the same and doing great, and didn't have his cowboy boots on, so I knew he was retired.
Right.
And he's like, he still liked to come and watch the games, and he was, again, we'd go 14, 16 hours away, and he'd be our only fan.
That's so sweet.
We always had Tim. So.
Oh, you're a fan. You're one
Tim's
fan.
great.
You want to put him in your pocket and carry him around with you.
I got that picture to keep him with me.
You support women's athletics in a big way, though. Tell us about the scholarship.
So it's just something I'm very passionate about and committed to. So we did create a scholarship, my family and I.
And who's that in the picture?
Yeah, that's Bruce Rasmussen. But that was a big benefit. That's actually coming up here in a couple weeks up at Creighton. So basically I made a scholarship for student athletes like me who were solid athletes but not the star, who stuck with the team. So it's specifically an athlete who on underfunded, so meaning NCAA allotted scholarships, is not fully allotted, and there's only 2 teams at Creighton that have their full possible scholarships, but it's for those athletes who show up as a sophomore, junior, or senior and really aren't getting much to play other than they just want to be a part of the team and continue to pursue something they really love. And it's meant to give them a little bit of a scholarship, let them know somebody cares, and we want them to continue to work hard and be a part of a team, be a part of the memories.
That's awesome. And now we have from college athlete to world traveler and world-class cook.
Oh, gosh.
You sent us some really cool pictures. So, Dr. Reddy, you travel the world during your free time, which is weird because I didn't think doctors had any free time. Where is that picture taken and who are you with?
That first one was in Machu Picchu. So in Peru, we went as a family. We traveled with my mom and dad also. So it was kind of fun, big family trip. We had a lot of different, I like to go to the places where world is so big and you're really small. It kind of grounds you and makes you more, I think, relaxed about what you're doing,
What's on your bucket list for travels?
Actually, I want to go to Galapagos this year, so that's our coming up plan. I often joke with my residents that I live from trip to trip. you know,
I love that.
So I love planning for the trip as much as going to the trip. So
oh yeah, it's a high to be planning. And then you sent us some pictures that made us all hungry. These aren't just like, oh, I made some cookies in the kitchen. These look like gourmet restaurant. You made that?
Yeah, we made it.
How did you learn to cook like that? So
this was all like, I love to cook always. I don't like to cook daily food. I like to cook like special food.
When are we coming over?
Huh?
When are we coming over?
Whenever you tell me, I'll make the menu you want.
I feel like you've made us all very hungry. So this is just in your downtime.
Yeah. So
downtime.
Because I mean, it relaxes you, right?
Yeah,
so you have
sure
to find
does.
things that ground you and relax you. So.
Well, thank you. Thank you for sharing those and making us hungry and for making us feel lazy with your college sports. I love it. I love that you started a scholarship. You know, we've been saying it all morning. Women can have it all. In addition to menopause, unfortunately, that also includes heart disease. Here's nurse practitioner Shirley Verbenik with why it's so important to know your risks.
I have women that exercise, eat right, maintain an ideal body weight, but have a really strong family history, and they have plaque despite their healthy lifestyle, but they think, oh, well, my mother smoked or my father smoked, and that's why they had heart disease. But it's genetic and lifestyle. So while these women are doing the right thing, which is great, and it's helping, but it's not completely stopping it. If you know your numbers and know your risk, there are other measures you could take, such as medications, that could help prevent those blockages from occurring.
Boy, and that's exactly what our patient, our Kansas City mom, Shannon, is doing right now. She's knowing her risks, and that's pretty cool. Thank you for being with us today, and thank you to our incredible doctors for being here and making time to join us, and thank you to Shannon, our Kansas City mama at home. Next week on All Things Heart.
It's freeing. That's the best way to describe it. It's amazing to be able to just get up, take a car key, go out, and go.
A local woman spent 20 years being told by all sorts of doctors that nothing was wrong with her until she came here to the health system and finally got answers from our doctors. The surgery that gave her her life back next Thursday morning at 10. See you then.